started?
We are ready.
Thank you, Madam Administrator. Good afternoon, everyone. Welcome to the last meeting with DSS for the appropriations budget for them. Good afternoon, Commissioner and your staff, and thank you for being here. We appreciate it. I think that we're going to dive right in because time is never our friend in this on appropriations. So we had some follow-up questions, and because there's only a few, it might be easier just to go through them real quickly. And then we will open it up to committee members if they have any questions on these or any follow-up questions. So number one, detail Medicaid provider relief, or perhaps show a side-by-side along with the CRF relief. That's Exhibit 1. Committee members, have you had the opportunity to take a look at that? Commissioner, do you want to add anything to that? And then we'll open it up to questions.
Thank you, Representative, and good afternoon, everyone. Happy to be here with you this afternoon. So Exhibit 1, we have shown the list of providers who have received some type of relief over the course of the pandemic and the source of those funds. And then you'll see that there are two columns. One is for the funds that were distributed and one is for the funds that were allocated. And the reason for that, and there are some annotations associated with that, the reason for that is because in some cases, we budgeted or had allocated a certain amount of funding and made that available. But for a variety of reasons, providers either did not have costs that reached that level, or they may have received supplementary funds from other sources. So we wanted to show you both what we had budgeted alongside with OPM, but also what was actually distributed to the providers. So happy to entertain any specific questions you have on that list, but that's the details behind that table.
Thank you, Commissioner. Questions, colleagues? Seeing none. I just want to make sure I'm not missing anybody on the Zoom. Okay, seeing none, we will move on to item number 2, which was check on the home health aid and waiver services minimum wage increase to confirm it went to all providers. That's Exhibit 2.
Right. Exhibit 2 is a list of all the different services that we included. And we did confirm that the minimum wage increase was received for all of the home health aid services and for all the low wage service categories in the waivers that are on the attached list. And the state funded home care program for the elderly was also included. So Kate and Dawn are on if you have additional questions about how that was implemented or the list of services included. I can't recall whose question that was, but we did attach the full list of services there.
Thank you. That was my question. I have heard from some home health providers that they did not get the minimum wage increase. So I must have been misinformed. So thank you for this. That's really helpful. Any questions?
Specifics, Representative, please, I know you know how to follow up with, through us, but if there's a specific entity or agency that has questions, we'd be happy to look into that.
Thank you, Commissioner. We appreciate that. Any follow-up questions on this particular question? Senator Kushner.
It's not exactly on this, but I think it relates and it would come up otherwise. In your responses to our questions, you responded there had been no consideration in the budget given to wage compression as a result of the minimum wage. And so you've accounted for minimum wage going up appropriately to all of these folks, but there's, as I understand it, there's been no looking at where we have to improve wages to avoid wage compression. Is that correct?
You are correct that there is there's no further adjustment to these services. Yes.
So I guess at some point in Representative Abercrombie, maybe this is a little late in the game to ask this question, but I do think it would be helpful for us to know in those agencies or amongst the providers where we are going to see that wage compression. You know, if you could give us some idea of what that's going to mean. Is it going to mean that people who maybe after several years in these positions have moved up $1 or $2 above minimum wage are now going to be back at minimum wage? Now, I think at some point we need to figure that out and see what it would take to address it.
Commissioner, is that something that you guys would have information on? Do you get to see the whole salary range for all of the employees in these providers?
I'm going to defer to Kate and Dawn on that one, Representative.
Sure, whichever who would like to answer.
Thank you, Representative. Kate Mcavoy, Director of Health Services at DSS. Certain Medicaid provider types, we receive what are called cost reports, which would provide extensive detail on the kind of iterative detail on staffing. So nursing homes would be an example of that. Home health organizations, we have not historically used cost reports. So this is something that we may move forward on from a standpoint of providing that level of detail. But I will just reflect that the minimum wage increases that we've implemented have reflected policymakers' concern around the direct workforce. So they have focused on the codes that you see listed in the exhibit. Typically, the folks who are performing the hands-on assistance, the home health aides, the personal care assistants, not the skilled and licensed positions like nursing. So those schedules have not been affected. So we are essentially focusing on individuals who've historically been low-wage workers. If there's interest in broadening that scope, we can talk about kind of best available methods to capture where those licensed individuals are relative to costs and relative to sister states, but we don't have standing means as we do for some of the residential or institutional providers to do that.
Thank you. I appreciate that. And I recognize, as I said, it's a little late in the game, but it did something when I reviewed everything over the weekend. I did notice that issue had been flagged. And so I wanted to make sure that we're aware of it and see if there's anything we can do going forward to look into that. Thank you.
Thank you, Senator. Any other questions on this particular issue? Seeing none, let's move on to item number 3, which is the residential care home, the submitting of Medicaid billing. I think a few of us were a little concerned that the numbers that are in the budget, if we will be able to achieve those savings. We have heard from the residential care homes that they're very concerned about this. So we were just kind of looking for more detail. I think that one of the things that will be helpful is that I believe that, hi, Senator Flexer. I believe that because it's the way the budget is, the way it's written up in the budget, it's only a 2-month because it doesn't start till April of 2022, which means it gives us a little bit of opportunity to see if these dollar amounts are achievable. And then from there, if we have to make any adjustments in the budget, we still will have time next year. But I thank you for this information because, you know, my only concern is as we go down this path, and you know that I never want to leave any dollars on the table. So if there's a way that we can get 50 cents on the dollar or whatever for that particular network, you know, that we do that. My only concern is that the residential care homes year after year after year say that we don't support them financially enough. And yet what they do, you know, if we lose any of those residential care homes, we don't have another network that can step in. So that's always my concern, is to make sure that we're supporting our providers that are out there. So Senator Austin, thank you. So thank you for that. Any questions on this particular issue from colleagues? Seeing none, Moving on to number 4, which is a complete 3-year client information. This was Representative Dathan's. Representative Dathan, do you have any follow-up questions on this?
I'm just taking a look at it now. Thank you, Madam Chairman. But it looks good, and I really wanted to commend DSS for pulling this together for me. This was really helpful in my analysis. If I have any further questions, because unfortunately I've been tied up in meetings this morning and just looking at it in the last sort of few minutes, but overall it looks great. I will follow up with the Commissioner and her team if I have anything. So thank you for pulling that together, Madam Commissioner, and thank you, Madam Chair.
Thank you, Representative. Does anyone else have any questions about this particular slide? Seeing none, we will move on to the next, which had to do with the minimum wage increases, which I think we talked about a little bit on who was getting funded and what the minimum wage, if everybody was included in that. Does anybody have any questions about this particular slide? So I think what we could do at this point, if anybody wants to open it up for any follow-up questions on the budgetary issues that are before us as a subcommittee, because after this we'll be meeting with OFA, now's your opportunity to ask the commissioner and her team those questions, which will be helpful to all of us in the decision making. So with that, I'll ask my colleagues, do you have any follow-up questions on any part of the budget? Wow, really? That's it for DSS?
Representative Abercrombie, give me 1 minute. I think I did have something that I need to find it in my notes.
Okay.
Oh, I do have a question about, and this is probably a more general question. It's not just for DSS, but it is something I noticed in our budget sheets. There's separate transfer information from funding from RSA to the agencies for collective bargaining agreements. And I just wondered if in fact,
kind of if they are helping us in that navigation.
Senator Anwar, can you please mute your, thank you, sir. Go ahead, Julie. I'm sorry. We missed part of what you said. I apologize. You're on mute, ma'am.
see, I'm so quick to go back to mute. I was waiting for the answer. I was just asking whether this is a new way of looking at the RSA account and the way the thing is done, or if this is something that has always been done in this way, you know, separating it out by agency.
I'm going to defer to Mike on the answer to this question.
Sure, thank you, Commissioner Mike Gilbert. So I would like to say that I believe I've seen it approached in both ways. Sometimes there are general pools of funds that are set aside through the RSA, and our wage increases are distributed to us through that mechanism. In other cases, there are more direct allocations. So I cannot speak to why in some cases it's handled differently, other than it's a general OPM decision in terms of how they construct the governor's recommended budget. But have seen it done both ways, direct allocations and the RSA distribution method over the many years that I've been with the state.
Thank you. Thank you for answering that. I had another question about it's on the budget sheets again, and it's related to the providing of funding for COVID-19 vaccine administration.
Senator, could you just tell us what page you're on? It should be on the top right-hand corner.
Just under my, it shows up under my staple. Page 10. I wanted to be sure I understood this piece of it about, about how the vaccine, where this piece of it comes from. Because I know when people go to get vaccines, they're just providing their name and they're filling out NAMs or some other form to get into the vaccine schedule. But does this reflect the number of people that also are covered by Medicaid? I wasn't sure I understood that piece.
So Senator, I'm not specifically looking at the same document that you are, and so I can comment in general, and then I'll turn to Mike and Nick to explain that particular budgeted amount. In general, our providers are being paid to administer vaccines. The vaccine itself is free. The dose is being provided to us by the federal government at no cost. The vaccine administration in general is being billed to insurers, and that includes Husky, or it's being covered by FEMA in certain cases where billing is not practical or feasible. So when we go to get our vaccine, the vaccine administrator is able to bill our insurance company for a fee that they normally would get to administer vaccine, and that includes our Husky providers. So Mike, I'm not sure if you have the number on page 10, what that particularly
Sure.
refers to. And I will add that one of the provisions in the American Rescue Plan Act does provide for 100% federal match for Medicaid vaccine administration. So for every individual that we administer a vaccine to that's covered by Husky, we will not have to pay any state funds for that cost. And that's obviously a new development. Go ahead, Mike, over to you.
Sure. So for those who don't have the document handy, there's a short write-up in the budget sheets that refers to the provision of $10.7 million in SFY 2022 associated with vaccine administration costs within Medicaid. So in this particular case, for all providers who are administering the vaccine, with the exception of FQHCs, we are paying the estimate is predicated on paying the Medicare rate, which is just a shade under $17, I believe, for the first dose, and just slightly over $28 for the second dose. So those constitute a large share of what you see here in terms of the $10.7 million estimate. In addition to that, there's anticipation that a good portion of the vaccines will also be delivered through the FQHCs. And so the FQHCs are estimated, are included in this estimate as receiving their full encounter rate for the vaccination, which is in the range of $160 to $170 per visit. So those two components contribute to the estimated cost that you see here for vaccine administration under the Medicaid account.
So just based on what you just said and what we heard from Commissioner Gifford, do we anticipate this amount of money will be, that we will find federal funding for this because of the American Rescue Plan?
So I believe that that's our anticipation. I don't think we've seen the full guidance to be able to know exactly how that will play out, perhaps most specifically in terms of the FQHC sites and how vaccine administration costs will be covered in the FQHC sites. I don't know, Commissioner Kate, if you think there's anything else to add there, please feel free to jump in, but that's my understanding of the current situation.
Go ahead, Kate.
Oh, I'm so sorry. I beg your pardon, Commissioner. Yes, we had the opportunity to speak to CMS leadership about this a week and a half ago, and they anticipate releasing a state Medicaid director letter providing those types of kind of more implementation related details to which Deputy Commissioner Gilbert referred. It is not yet clear. I mean, there's broad language enabling the federal coverage but how that will translate in terms of particularly the health centers or the encounter rates, we have to be advised on that.
Thank you so much for that answer.
And I would just say that's sort of a recurring theme with the ARPA. Obviously, federal agencies haven't had a lot of time yet to develop the guidance. So although there's very high level language about a lot of the funding provisions, we anxiously await the guidance from our federal partners to understand how and for whom the money can be spent.
But there's hope. That would be a good thing. Thank you.
So to follow up on Senator Kushner's questions about and I think it goes to the American Rescue Plan funding. Do we have, I know that you've been working on looking at the guidance and how it needs to be spent, but do you have a dollar amount that we will be receiving? And is it outside of the 128 million, which is the 6.2% increase to Medicaid? So are they also breaking those dollars down to enhance matches in other areas?
Yes, and in fairly limited circumstances, Representative, and we included in the materials that we sent over, I know it was a lot, but there is a nice slide presentation that was prepared that has some high-level summaries of the Medicaid features in the ARPA. The enhanced match is, there's some enhanced match for home and community-based services under particular circumstances. Again, TBD, we don't have the full guidance.
What's TBD?
To be determined.
Okay.
On the home and community-based services. Sorry about that.
That's okay.
And there is some significant enhanced match for states that have not yet expanded Medicaid. So obviously we don't qualify for that particular benefit of the legislation. There is not enhanced match, but a state option to extend postpartum care to a full year. I think we had talked about this in a previous hearing. They chose not to put an enhanced match there, but just to make it easier for states to extend postpartum care for a year without having to apply for a specific waiver, just as an option in the state plan. And then there's some provisions around drug rebate that are sort of still being worked through. I think, Kate, correct me if I'm wrong, I think that's the extent of the additional FMAP bumps that we can anticipate in Medicaid.
Sure. I'm so sorry. My attention was diverted for a moment. Did you mention the mobile crisis piece also?
Oh no. Yeah, go ahead, Kate. I didn't. Yeah, please do.
Yeah. So in the category of additional resources, the federal government has also signaled that additional match will be given for expanding community-based mobile crisis interventions. Those are supports for individuals experiencing a mental health or substance use disorder crisis. And that also begins 1 year following enactment of the law and provides a substantial additional match. So that's something that the state could consider. It would be at the 90% matching rate for services.
Wow, that's quite the match. Wow, 90%. So would that be under the DMIS? So because we are the gatekeeper for federal dollars, right? I mean DSS, sorry. I feel like a part of you guys sometimes. Does that mean that this would go through DSS, but this would be the mobile that they use in DMIS?
I think, Representative, this would be something that we would collaborate closely with DMIS on, since they already have those crisis units.
Right.
They would likely be the implementation arm, and we would apply for the enhanced match. But we haven't sort of worked through those details yet. They're also getting significant funding, as you know, through SAMHSA that will go likely directly to those DMIS operated programs as well. But this is specific to Medicaid funding and match, so that this can be a statewide resource that would be at very low cost to the state.
And
Commissioner, I'll just wrap around. I beg your pardon, Representative Abercrombie. I'll just wrap around to say that Another really important example is the DCF mobile crisis.
What I was gonna ask.
So again, through the behavioral health partnership that is operated by DCF, DMS, and DSS, there's really a great vehicle for examining ways to optimize this. And I do have to apologize that it is 85% match. There's another section of the law that refers to not displacing the 90% match that we have for Husky D, our expansion population, but I don't want to overstate good news. It is 85 rather than 90. So I apologize for that error.
85 still good, better
Yes.
than the 50. So,
Yes.
and that's
Yep,
great
it
to
is.
hear about the DCF because I'm hearing from communities that that is something that's really on the rise. So it's good to know that we have the ability to help not only DMIS, but DCF with that. So that's great. Just to follow up on the American Relief, and then I'll go to my two colleagues, Representative Betts and Representative Dillon, that have their hands raised. When we talk about the expansion of Medicaid, and I know we were one of the first states that took advantage of that, right? And that was our LEA, if I'm not mistaken, our LEA population. Has there been anything in this relief that has given us more funding, because we know that that population is also has the growth of that through the pandemic with people losing their jobs. So are we able to maximize some of that federal dollars that we already have through that program? And I don't know if you want to turn it over to Mike or Kate, Commissioner.
So can you say what you mean by LEA, since that probably predates me, Representative?
Sure, I'm sorry, the low income, oh, help me, Kate, sorry.
Yeah,
Low income adults,
low-income
right?
adults. Yeah, that's
Okay,
that's
what I
our
thought,
Husky
yeah.
D
Or
group,
expansion
Commissioner.
population. Yeah.
Yeah,
So a couple of things I would say is, the enhanced FMAP through the conclusion of the emergency, I think is that it does not apply to that group, right? Because they're already at 90% match. So we're already receiving for the expansion population, and will receive in perpetuity 90% matching rate on the expansion population. What is in the American Rescue Plan Act, which is not under DSS's purview, but just for your own information, Representative, is very significant enhanced funding for people who are buying a plan on the exchange. So to the extent that an adult is above the 138 FPL for the expansion population, federal poverty limit for the expansion population, and they choose to purchase insurance through Access Health Connecticut, there are very significant and substantial both tax credits and cost sharing reductions as part of the American Rescue Plan that will make it either very low cost or essentially no cost for individuals to purchase plans on the exchange. So that's another very exciting part of the plan in terms of getting more people covered.
yeah, I agree with you. We're just starting to get details about that, how this can really help small businesses and individuals. So that I agree with you. That's really exciting, especially in these times. So thank you for that. Representative Betts, followed by Representative Dillon.
Thank you, Madam Chair, and thank you, Commissioner, and to your team. I had a question pertaining to the vaccinations. The money that's been set aside to give vaccinations, is that based on 100% participation, 90% participation?
Go ahead, Mike.
Thank you, Representative. I can check very quickly as to what the actual assumption was, but it definitely was not based on an assumption of 100%. I believe it was based upon an assumption of 75%, but I would need to double check the estimate to be certain on that number, which I can try to do quickly.
You know,
if we want to swing back to that.
That's really not necessary, but I'm just kind of curious because for those people who refuse to take the vaccination, I'm kind of curious as to what the plan is there. And the other thing is the money that you set aside or budgeted for the vaccinations, can that be used for something else, or is it exclusively dedicated for vaccinations?
So I would just add to that generally speaking, the funds are appropriated to the Medicaid account. The Medicaid account has, I would say, flexibility within the structure to allow for funds to be used, based upon need within the account. That being said, clearly we're operating under policy guidance, statutory limitations or guidance around how we carry out the various provisions of Medicaid. So we don't have, I guess, sort of open authority to reallocate them to other things unless there is a driver, a cost driver within the account that requires additional support, and then the funding could be used in that way.
Okay, thank you very much. And thank you, Madam Chair.
Representative Dillon?
Thank you very much, Madam Chair. I was going to ask you about mobile crisis, and actually you brought it up. So if we could flag it for future cooperation, because that came up a lot in the testimony at the public hearing on the budget. Number one. Number two, it's still kind of unresolved, but I know that you didn't do it, but the cut to the rates paid by radiologists seemed very arbitrary. Again, it was a previous administration and so forth, but I never could figure out why that was done. Number three, which I think is a joint responsibility or a collective, on the C-sections. I haven't had time actually since we were last together to look at the birth outcomes. But it is a little concerning that the previous intervention did not move the needle with African-American births. And I think Representative Abercrombie suggested maybe nurse midwives. I like that idea, but it's also true that even if I don't look for low birth weight, we know there's an association with developmental disabilities, although it's complicated if there's a high C-section rate. So if wearing two hats, Commissioner, if we could think through something that would promote healthy babies at the same time we could do justice to what's going on in the budget, that would be really helpful.
If we could, oh, I'm sorry, Commissioner. What I was going to say is if we could, and Commissioner, if it's okay with you, I'd like Kate to explain a little bit what the thought is around the bundled rate and how DSS feels that would help with the low birth rate outcomes. So Kate, would you, and I apologize, well, I'm not going to apologize, you're good at this. So if you would just kind of explain about the bundled and how you think that will be a better service.
Thank you very much, Representative Abercrombie. Again, Kate Mcavoy, Director of Health Services. So I do want to honor what Representative Dillon said. The interventions that we have put in place today, which include perinatal intensive care management through our medical ASO, and also a pay-for-performance obstetrics approach, have had positive impact, and specifically on timely identification of pregnancies, so early in the pregnancy, on engagement with prenatal care and postnatal care, and some impact on the incidence of cesarean births. But it has not, as you exactly correctly observed, it has not had significant impact for women of color, particularly Black women. And on that basis, as well as other concern around adverse outcomes, including devastatingly maternal death, we are focusing on the bundle because we want to draw a more expansive window around the array of services that, starting with first notice of pregnancy through the birth of a child, really can helpfully enable and increase the probability of a healthy outcome. So yes, the obstetric support and or the nurse midwife support, but also we are looking at folding in services like doula supports, which have for which there is some evidence base around supporting both pre and post labor. Also interventions such as community health workers, which can reflect lived experience among women, especially from a cultural standpoint. And finally, following the birth of a child, we're looking at a breastfeeding intervention that has been actually recognized by the WHO, which was inaugurated and built out by the Hispanic Health Council and Trinity. So we have local expertise that we feel will really bring to bear on encompassing a payment that will not only cover a longer duration of time, not simply the birth, but a longer duration of time, but also give more flexibility to providers by paying in a fashion that will enable them to flexibly apply these interventions, as well as telehealth, telemonitoring, and also really looking at aspects that relate to equity. We are very privileged to be joined by the Yale Center for Outcomes Research, a nationally recognized entity that is concurrently advising us on how we build in measures to ensure that we are tracking and seeing improvements, particularly for women of color. So this is a very significant collective effort. We're also joined by ACOG, by Planned Parenthood, by the Association of Nurse Midwives, and diverse other types of stakeholders, including health centers, really in framing the bundle in a way that's going to be as thoughtful and comprehensive as possible, exactly to the ends of improving the outcomes to which you pointed.
Representative Dillon, any follow-up question to that?
Yes, I do, Madam Chair. I mean, the difficulty before us is we're looking at a budget that has a cut in it. We're assuming a savings based on a reduction in those procedures. But we have another issue which is related and compelling, which is what's happening to the children that are born and to a certain extent in our own care. I'm heartened by the response that I've heard from you, Ms. McAvoy. I would like a little bit more detail later. I think everyone would share that this is a very important issue. And if you're looking at different kinds of caregivers as well to provide, that could be very good. I've been hearing a lot in another committee about transportation in Hartford. I know that there's an issue here, but as well where I live, but I don't know, I don't have a magic answer, but it sounds like you're starting to work on it and we'll continue to have a conversation. Thank you.
Thank you, Representative. Follow-up questions, colleagues? So I have a couple of follow-ups. So when we talk about annualizing the holdbacks, when we talk about personnel services and other expenses, if you look, and I'm sorry, I'm not sure if we're looking at the same document, but I'm looking at the OFA write-up, which is page 5. There's probably approximately 4, 5, 6 million in those two lines. Is that a reduction to personnel services? And then in the annualize the rescissions below is another 1.3 million and other expenses 1.1. Can you give a little bit of details? Does that mean that you're not hiring back or you're not hiring for areas where you need more employees? What does that mean?
Yeah, it's a good question, Representative. And I'll just start broadly and then Mike or Nick can provide further detail. But in our original testimony, I think per your request, we provided the number of authorized positions and the number of funded positions and then the number of actually filled positions that we have at DSS. We are at the moment still well under our funded positions. So even though there is some savings by not hiring fully up to our cap, we still are in the process of hiring and continue to replace, as we lose them or as there are retirements, we continue to replace our eligibility service workers and other positions and have a ways to go before we hire up to our funded positions. So does that answer your question or do you want a little more detail from Mike?
So I guess the question is, and yes, you gave us the detail in the first document, which I'm looking at now, right? So when you make those reductions, the way it's written up in the budget, right, that the holdback and the rescission will be annualized, right? How do you get the flexibility to be able to do these hires? Because according to your document, right, there's about 120 unfunded vacancies. So why are we not keeping that money to backfill those vacancies? Because in all honesty, DSS has never had the amount of employees that they need. I mean, look at the call wait center, right? I mean, that was, hours people were waiting. So why are we not taking, since we have this money here, right? Why are we analyzing those cuts and not reinvesting it back into your agency?
Well, I'll let Mike respond as well, but I think just, in the overall, looking at the overall budget, and I'm assuming there were impacts to each of the agencies in order to meet, the budgeting targets. There was some annualization of lower staffing levels. But so I understand where you're coming from, Representative. I would just say that we have been able to continue to hire and staff at levels that the agency it can fully operate under. And as I said, we continue to have a number of open positions and are continuing to hire as we speak. So Mike, do you have additional information for Representative Abercrombie on that?
Yes, thank you, Commissioner. I think the only thing that I would add is just for context around your question, Representative, is that we are currently somewhere in the range of 1,600 positions. We believe that even with these holdbacks and reductions to PS, we will be able to get, somewhere, we're estimating that we would be somewhere around 1,776 positions that we will be able to fund with the appropriation as presented after these adjustments. So, clearly we have, approximately 175 positions that we are actively recruiting for and hope to bring on board, before the beginning of the year. But, recruitment continues to be challenging in order to, the remote process. There are bringing on that many people all at one time. The recruitment process does take time. Like I said, we are hopeful that we will have all those positions on board as we enter into the new year. But then, of course, we're going to have another round of additional retirements and other things that are going to occur. So that's a long way of saying that, the appropriation would be sufficient to get us up to that 1,775. And, with the normal flow of recruitment, that probably is a fair number to assume, for us to be able to staff up to for SFY 2022.
So go ahead, Commissioner.
Yeah, I was just going to add, with respect to your comment about the call wait times, just so you know that that continues to be a focus for us at DSS. And we have been working even through the pandemic, although it has slowed a little bit because of, the remote work, et cetera. We're continuing to work on ways that we can improve the flow of calls and also give people more options to do things online or on a mobile app so that they don't need to call. We were able to, limit some of the in-person appointments that needed to happen in our field offices over the course of the pandemic. So we're going to continue to look at ways that we can optimize that, because we agree with you, Representative. We want to see the shortest wait times possible. We have made progress, a lot of progress in the time since I've been here on shorter wait times and fewer days when we have really long wait times at the beginning or the middle of the month. But we are continuing to invest in strategies, both human and digital, that can improve access for people that are seeking benefits. It's very important to us.
So let me just say that I have talked to many employees of DSS, and let me just say that they are feeling very, very, very overwhelmed, not just through the pandemic, but in general. I've been here long enough and I've seen the cuts we've had to make. to DSS, which we're not comfortable. Let me just say for the record, I'm actually surprised that since you had the opportunity with these dollars to kind of backfill even more so than just the immediate numbers, that you're not taking advantage of that. And I'm fearful that the people that have the knowledge base, just like I think you are too, are going to be our retirees. And I think that DSS going down the road, and I'm talking, 22, 23, are going to be in big trouble because you're going to have a big draw on that knowledge base. So, if I was you, I would be backfilling those positions right away so that this turnover, you have the right people in the right place. Because I agree with you. I don't think it's easy to fill these positions. It's a level of expertise that takes time and training to do. So I'm just voicing my concern when we start to look at the next budget. And I know we haven't even gotten the 22-23 budget done, but we all have to be aware that in 2 years from now, we're going to be in trouble with employees across the spectrum of agencies. But my focus is more on the human services and currently you as DSS. So I just want to voice that. Representative Walker, so nice to see you.
Thank you, Madam Chair, and good. I was going to say good afternoon, Commissioner, but she's gone. Okay. Oh no, there she is. Sorry. Good afternoon, Commissioner. It's good to see you. Good to see you and all your staff. I apologize. I was listening to everything that everybody was talking about, and it sort of. So, is it possible? First of all, how many staff are vacant right now? How many positions are vacant right now? I didn't hear Mike's numbers. I'm sorry. I apologize.
Good afternoon, Representative Walker. Nice to see you. Mike, do you have that number in front of you?
Sure. To your question, Representative Walker, we're currently at approximately 1,600 positions, filled permanent positions. We anticipate that the governor's recommended budget will support 1,776, give or take. I believe our authorized count is 1,985. So we have approximately, 175 or so funded vacancies, and an additional 110 or so in unfunded vacancies. I just wanted to quickly mention, we do have approximately 180 positions in active recruitment processes or requests for movement. So we do take, Representative Abercrombie, we do appreciate your points around where we need to be for 2022. And we are trying to position ourselves as best as we possibly can through a range of recruitment activities at the moment.
So, Madam Chair, if I can be indulged with a couple of quick questions. So I'm very curious about what is the volume that we have going on the online system that you mentioned and the mobile app. How long have both of those been in existence? They've been in existence since the pandemic?
So the mobile app work is ongoing. We continue, people can view their accounts through their the mobile technology, but not make updates. So the work that we're working on now is to allow people to do more without needing to make a phone call. Mm-hmm. Kathy or Peter might be able to provide an update on a current date for that. We have continued to upgrade our phone technology during the pandemic because we were having so many calls at certain points to help give people other self-service options. Many people call. In fact, in some weeks, Representative, it's the majority of calls. They just want to sort of confirm whether their application has been received, whether it's in process, what the status is. And we understand, people are anxious to see how their benefits are being processed. So we're offering more direction as to how they can access and view their account to get that information. But our goal on the mobile app is to provide them with the ability to actually do more updates without needing to call us or have a wait time in one of the offices. Kathy or DC Brennan or Peter, anything to add there on that?
Good afternoon, Kathy Brennan from DSS.
Hi, Kathy.
I think it's nice to see you. I'll let Peter talk to the mobile app, but the commissioner stated everything that we're moving towards. In addition, we are trying to focus on how to get our clients more and more comfortable with using online and community partners to help them use and apply for benefits online. We've made, as the commissioner stated, a lot of advancements in our technology. The virtual hold technology has been really very helpful for our clients. Peter can speak a little bit to that, but I do just want to note that last week, our average wait time on the call on the phone was 10 minutes. So a significant improvement from what we were seeing even before the pandemic, and then obviously at the beginning of the pandemic. But we certainly continue to focus on whatever efforts we can make to change and further reduce that wait time. Peter, if you want to chime in.
Before we, excuse me, just before you say anything, did we get the let's say a few months of how long the wait times were? Did we get any data from that in the information that we got from you guys? Because I didn't
don't
see
think
it.
so, but that's certain. We can certainly get that to you, Representative Walker. That's
Yeah.
yeah, I can get that to you very quickly.
Okay, it would be good, and I'll let Peter tell me about the mobile app, and then I'll ask my question.
Sure.
Thank you, Kathy and Representative Walker. Just a quick update to say, just to keep everybody informed, we have had an online presence and the ability to submit applications, renewals, and change requests since approximately 2014. That was part of our Connect project. What we're looking to do now is to optimize that interaction for mobile devices so that people have an easier time being able to get access to their phones, right sizing each screen so that it looks right when you're on a mobile device, making sure that the flow is more comfortable, and also understanding, of course, that there are a lot of people out there who have mobile devices that don't necessarily have desktop or broadband access. So the hope is to really expand the number of people who are able to use our online and electronic self-service to the extent possible, but also just another point of access with DSS. Just to touch quickly on what Kathy mentioned about the virtual hold technology, we did look at some numbers about how we think that it's really helping clients. An early estimate that we did suggested that we were saving clients about 1,000 hours a week of time on hold by facilitating return calls that they were able to opt into early in their call rather than waiting to talk to a person. But we can also provide additional information about the call wait times, as Kathy indicated.
I would really like to see what the call wait times, and I'm impressed with the 10-minute wait time. I'm sure there's a caveat in that because most of the time when I talk to people, it's never been 10 minutes. And I mean, the other part is everybody is not as friendly with technology usage as we saw during the pandemic. It became kind of a sad story for so many people. And even though we've had the access, it doesn't mean that people who actually had the ability to make the access. And as you know, when you use these devices, it's very hard to see those little buttons and those little boxes and things like that. And it makes people, especially people who have special issues, special needs, visual issues, things like that. This type of device is something that is extremely limiting. So we have to remember that your population that you're serving are people that have needs, and how do we address those needs in a way that helps them become more proficient. But I'm glad Kathy brought up the community partners. When I hear about the application process, I look at what are we doing with our community partners? Are they participating? And when Tony Walker fills an application with Community Action Agency here in New Haven, how long does it take for me to get notification from Department of Social Services, since we haven't got a direct line going to it? How long does it take for me to get that information?
Well, I think that depends on the program, Representative Walker. And If it's, if it's SNAP or Medicaid application that you're receiving assistance with, you will receive very timely response. If it's one of the other less electronic, more paper-based programs like heating assistance, might be a little bit longer for the determination to come back. So it probably depends on the program that you're applying to.
Okay, all right. So the online, you have time, you have start to finish timelines that you can share with us on how long it takes. And on the mobile app, you have the same type of materials that help us to understand the efficiency of where we're going in that direction and how it connects with people. Could we get those numbers from you?
Yes, we have, our federal partners are very interested in our application timeliness, appropriately so. So we have those numbers at the ready we can share with you. And then be happy to get you an update on the mobile app.
Awesome. Well, thank you. And my final question is the number of people that you have in the number of people that you have filled versus what, and Mike, it's according to your sheets, it's 1895, not 1995. So, because that really scared me when I heard you say 19. It was, I understand. But what I'm trying to understand is if we have that many vacancies, do you know where these vacancies are in your agency? Do you have an accounting of, are they in the SNAP? Are they in the heating assistance? Are they in any of the other programs that you ran? Do you know where they are located in your agency?
Yes, we do, Representative.
Could we get that information too? That would help us in everything that we're doing right now. Thank you, guys. And I'm sorry I chimed in at the last minute. It's just got too many Zooms going on, so I apologize. Thank you. Good to see you all.
Thank you, Representative. Senator Austin?
Thank you very much. Appreciate it. I just have one quick question about VAO. What is the situation with VAO now? How are we moving forward with VAO? And my question is relative to the fact that I'm still getting calls from people who say VAO picks us up early or late, and a lot of times they don't even show up to pick us up to bring us home. So what is going on with VAO these days?
Go ahead, Kate. You want to give an update on the contract status?
Sure. Thank you, Senator Austin. I appreciate the question. Kate Mcavoy, Director of Health Services at DSS. So first of all, I want to confirm that both the department and VAO remain extremely interested and concerned in making sure that Medicaid members get timely to needed health services. That's a shared interest. As you know, VAO serves as our broker for transportation services, working with myriad local providers, notably delivery providers. And VAO has an established process for putting in place corrective action plans for any provider that is not adhering to timeliness standards for pickup and drop off and other performance standards around the cleanliness of the vehicle, the ride experience, et cetera. Those corrective action plans are input into its ride management system. DSS has direct view into the ride management system, and we have staff who regularly are performing desk audits of those functions. So the quality from a standpoint of the indicators that I just pointed to is being assessed on a day-by-day basis. We have squarely identified with VAO that one of the most important key performance indicators is timeliness, because that is really the leading evidence of the service being effective. There are other pieces that we're looking at also around ride experience, the complaint data, the grievances, and all these factors are being monitored very religiously by DSS. We're also producing a dashboard of indicators of these pieces that is published on a monthly basis on the dedicated webpage that DSS maintains. So we can send through the administrative staff of the committee the link there so you can monitor that yourself. And I will say that the BAO contract, which originally would have ended as of this past December, was approved by the administration for an extension substantially related to the public health emergency interfering with our ability to timely reprocure. It was extended for a 1 year and 3 month period, so through the end of March of 2022. DSS will issue a procurement this year for the transportation broker services. And so we will obviously invite qualified candidates to bid on that for the period that starts April 1st of 2022. I'll just wind up by saying that BAO incorporated the overwhelming majority of recommendations that were made by the auditors of state accounts, and some remain actively in process, but we also were very vigilant about making sure that that occurred through a corrective action plan that the department established and is being overseen by Bill Halsey and our staff.
So I'm being told that, and I was talking to a provider, a nursing home today, and the person who does the confirming of time is regularly having to pick up customers or clients from their appointments because VAO just doesn't bother to show up. And they're saying they don't have any way to even check if VAO is applying to, could you hold on 1 second? Hold on. Yeah.
I think she has to vote with everybody being on multiple Zooms.
I apologize. I had to have them hold off on one of my issues. So nonetheless, they have people from the nursing home are going to pick up the aide that is with the person and the person to bring them home because they're not coming to pick up the person, and they have no way to check whether that is being applied to Medicaid because it doesn't, it's not approved by them. What do we do in order to make sure that VAO is charging for transportation that they have actually completed, both bringing them there and bringing them back home?
So Senator, first I would say that there is a well-established process if a ride is late, and again, VAO does not provide any transportation itself, it's a broker. There's a well-established process if a livery or other provider does not arrive timely to contact VAO. It's identified in the member brochure and numerous other types of communications, and we will be happy to.
So they did that. They aren't, I'm sorry, I don't mean to interrupt, Kate, but they've done that. They've called VAO and VAO says, well, we sent somebody there and nobody was there. And the people are waiting outside. And then they said, well, you have to start all over again and ask for someone to come here. They're using the process that's there, just that VAO is not responding. How do we make sure that because it's the direct to Medicaid payment, how do we make sure, and I'm not for switching in and switching out, I just want to hold the company accountable for what they're doing. What I'm trying to figure out is how can we make sure that VAO is actually doing the trips that they're charging directly to Medicaid?
So Senator, as I mentioned, that VAO maintains this ride management system, and our staff routinely does desk audits of that, of ride completion. So there is documentation in the system of whether a ride that's been requested has been fulfilled. VAO reports on that within the system, not only on an individual basis, but we roll up all those statistics into the monthly report that we produce. So it will show an aggregate of rides that couldn't be fulfilled for any reason, including the member not being available at the time of the pickup.
So does VAO, does your system have a mechanism in which the provider or the place where the person is living can report that no one bothered to pick them up? There a communication tool in that, and can you send me that communication tool that who they would talk to at DSS relative to this issue?
Yes, Senator, I'm happy to send that. There is an established grievance process, and also there's a process for direct contact with DSS if that would be a help.
Direct contact would be best. Thank you very much. Thank you very much, Madam Chair.
Thank you, Senator. Any further questions or comments? Seeing none, thank you so much, Commissioner. Thank you to your team. We so appreciate you guys being here. We hope you have a great day. Appropriation members, please